why should we measure, what should we measure, and how should we do that measurement? So you've already heard today several times that the main reason to measure is because what gets measured gets done. You've heard that several times, and it's obviously true. What we're trying to accomplish with antibiotic stewardship, and you've heard this, antibiotic use in human medicine is extraordinarily common. Half of all patients who come into a hospital in the United States get an antibiotic at some time during their hospital stay. Similarly, in the outpatient arena, and you've seen this map already once, there's a tremendous amount of antibiotics prescribed across the United States. For every 1,000 people, depending on what state you live in, for every 1,000 people in that state, somewhere between 600 and 1,200 prescriptions are written every year. That is, in some states, more than one outpatient prescription per man, woman, and child in that state per year. That's a lot of antibiotics. And you've also heard that somewhere between 30 to 50% of those antibiotics are either unnecessary or inappropriately or inaccurately prescribed. So with all of that as background, what are we trying to achieve with antibiotic stewardship? Well, we have goals and we have objectives. The goals are improved population health. At the end of the day, the goal of antibiotic stewardship or any public health intervention is to improve the health of the population. Another goal, obviously, is to have physicians optimally prescribing antibiotics. You've heard that over and over again. Antibiotics are not being well prescribed in too many situations. There's such a thing as optimal prescribing, and we'll talk about that in a couple of minutes. And the third thing, which has been nicely set up today, is you want sustainable changes in clinical practice. You want to improve prescribing for the long term, but you also want to improve every other aspect of clinical practice because the best stewardship intervention is preventing infections. That's going to eliminate the need for an antibiotic in that case. So you want to change practice not just to improve prescribing, but to change any aspect of clinical practice that's going to help you prevent infections. We'll talk about that too. To get to those goals, we have some specific objectives, some measurable objectives. Those are better clinical outcomes. If each patient has a better clinical outcome, population health is improved. We want to measure a reduction in antibiotic resistance and antibiotic-resistant infections. And measurably and importantly, there's an economic benefit, and we'll talk about that too. What to measure? So now we've talked about why we're going to measure it. What should we be measuring? And again, you've heard in the presentations preceding mine, again, obviously there's outcome measures and there's process measures. We care a lot about outcome measures, and that's the ultimate way that we know we're being successful, but we also know that outcomes are more difficult to measure, in some cases more expensive to measure. And so you usually need a combination of outcome and process measures. Let's talk about the specific outcome measures. We talked about better clinical outcomes. Well, obviously, you want to assure that there's less morbidity and mortality. You want less illness, shorter duration of illness. You want fewer patients to die. Those are better clinical outcomes. The aggregate of that is better population health. But also, as you've seen, we want fewer adverse events. It's not just about antibiotic resistance. Antibiotics are powerful pharmaceutical drugs. Like any other pharmaceutical drug, they have side effects. They have drug-drug interactions. There are allergic reactions. If we're doing a better job of prescribing and using antibiotics, we'll have fewer adverse events, including Clostridium difficile infections, which we'll talk about in a moment. One of the things we're talking about a lot today is reduction in antibiotic resistance. So certainly we should be able to measure a decrease in the number of resistant infections and have less spread of resistance, less colonization, less appearance of resistant bacteria in a variety of different settings. And the economic benefit to be derived is not just in lower pharmacy budgets. Obviously, if 30 to 50% of antibiotic use is inappropriate or unnecessary, or we're using too many expensive broad-spectrum drugs rather than off-patent, narrow-spectrum drugs, we can save a lot of money in the pharmacy budget. But also, if we're having better clinical outcomes, if we're having less illness, shorter duration of illness, we're saving a tremendous amount of money in healthcare costs. So let me go through these quickly because you've had some of this background already. Antibiotic resistance is the primary driver of Clostridium difficile infections. 500,000 infections a year, many deaths, billions of dollars in something that is increasing fairly rapidly. And not only are the number of cases of C. difficile infection increasing, but the mortality is increasing because there has been for the last several years a more virulent strain that is more likely to cause serious illness and death. And so since the primary driver of C. difficile infections is antibiotic use, by cutting back on antibiotic use, we reduce the number of those infections. And our estimate is that by cutting back on antibiotics by 30%, we could reduce the number of C. difficile infections by 26%. And obviously, given those numbers, I've given you 500,000 infections, billions of dollars in cost. That adds up to a lot. Similarly, and again, you've heard there's inappropriate use of broad-spectrum antibiotics where narrow-spectrum antibiotics would be just as good. Similarly, cutting back on the use of broad-spectrum antibiotics in favor of narrower-spectrum antibiotics would substantially decrease the number of C. difficile infections. So that is a very specific measure of success in stewardship. Similarly, it can be shown, and again, it should be obvious, but it's always good to have scientific proof, that if we're using these drugs better, if we're using them more appropriately, if we're targeting them better, and avoiding unnecessary drugs with all of their side effects, we're going to have better clinical outcomes. And yes, that can be shown scientifically, that good antimicrobial stewardship programs lead to better clinical outcomes for patients. Similarly, again, it's obvious, but again, it's good to have scientific proof. If we treat patients with antibiotics, they're more likely to become colonized and then infected with more resistant strains. And again, here are some studies that demonstrate that patients who receive antibiotics are much more likely to be colonized or infected with much more resistant bacteria, which the media, as we know, likes to call superbugs. So again, pull back on antibiotics, and that's true for the individual patient. It's true for the facility. Again, here's a study that shows that, and just follow the line, the more antibiotics are used, in this case carbapenems, the more resistant Pseudomonas aeruginosa you have in the facility. And this is a study looking at 45 long-term acute care hospitals. Again, if antibiotic use drives resistance both in individual patients and in facilities, studies can show that by cutting back on antibiotic use, you can have a significant reduction, at least in that facility, of resistant bacteria. The first column of numbers shows what happens in resistance rates before the program, the second column after the program, and significant differences in the third column demonstrating that programs will, in fact, bring those rates down. And we've already talked about money, but again, study after study shows that putting in place a good stewardship program will save, obviously, the pharmacy budget, which is the easiest thing to measure, but again, clearly, better clinical outcomes and better health saves money for the entire healthcare system. There are also process measures. And again, collecting the data for outcome, it's critical, it's important. We'll talk a little bit about that in the next section. But process measures are easier to measure, and there are three. One is, does the facility have a good stewardship program? Another is, are the physicians in that facility or in that practice following optimal prescribing patterns? Again, you heard Dr. Zaudas talk a little bit about that this morning. And the third, of course, is rates of use. That's a process measure. Less antibiotics is not an outcome in and of itself. It's a measure of process. Since 30 to 50% are inappropriately or unnecessarily used, if we improve prescribing, if we improve the way we use antibiotics, we should see less. But that's a process measure. CDC has just recently published what are the core elements of a good stewardship program. There are 7. Leadership commitment from the highest levels of the facility. Accountability. Who are the accountable persons in that facility for assuring good antibiotic stewardship? Do those people have the expertise? Do they understand the drugs that they're talking about enough to give advice and to oversee the program? Are actions being taken? It's more than just talking about it. It's more than just having a pharmacy and therapeutics committee. Are actions being taken to progressively improve the way antibiotics are used in the facility? Obviously, are you tracking it? Can you tell if you're being successful? Do you have a monitoring system in place? Are you reporting back the information? You saw again this morning in Dr. Zoutis' talk the extraordinary value of reporting back that information. That makes a huge difference in improving the way people prescribe antibiotics. And again, lastly, are you actively, in an ongoing way, educating all of your health professionals and, incidentally, educating your patients, educating your consumers? Are you doing a good job of education? So those are things that you can specifically look at and say, if you have these 7 elements, you've got a decent program in antimicrobial stewardship. So that's a recent publication. You heard Dr. Zoutis talk about variability. And if we're going to talk about measuring rates and measuring optimal prescribing, we have to recognize that there's extraordinary variability, as you saw this morning, in the rates at which physicians prescribe antibiotics. In the inpatient setting, in some hospitals, doctors are prescribing antibiotics at 3 times the rate in other hospitals with comparable patient populations. And again, the goal of what we do with stewardship is to improve prescribing practices. In human medicine, that is the choke point. Antibiotics are only available by prescription, whether it's in an outpatient setting or an inpatient facility. The choke point is the doctor writing the prescription. So is that doctor following an optimal set of practices for prescriptions? Is there a clear indication for the prescription? When the doctor writes the prescription, is it clear in the notes why that antibiotic is being written, what it's being written for, to allow you to assess whether that particular prescription makes sense for what the doctor thinks she's treating? That gets at this question of appropriateness. Is it consistent with, there are a lot of guidelines out there. There's IDSA guidelines, there's all sorts of guidelines from all sorts of professional associations. Is the prescribing consistent with those guidelines? Are you doing something that's very important? You remember you heard about the 5 Ds this morning: the right drug, the right dose, the right duration, the right delivery system, and de-escalation. One thing that would solve a tremendous amount of problems with antibiotic use is de-escalation. After 72 hours, looking at what antibiotic is being used. When a patient comes into a facility, you may not know what infection that patient have, what the causative microorganism is. You're going to have to treat empirically. You're going to have to use your best judgment. And you're going to err often on the side of a more broad spectrum drug, depending on what your antibiogram shows, and you saw the antibiograms this morning. But if you've done optimal prescribing, if you've gotten laboratory tests, if you've gotten microbiology, after 72 hours, you should have a much better idea of what's causing that infection. Are you going back and looking at the drug you've put your patient on and say, you know, look at that susceptibility. I don't have to use this big gun broad spectrum antibiotic, I'm going to be successful because of what this microorganism is. I'm going to be successful with a narrower spectrum drug that's going to help this patient get better. Or you just write it and walk away and leave the patient on it for 14 days. If we could get people to take that antibiotic time out, to de-escalate that therapy based on having done the right kind of laboratory tests, that's going to make a tremendous difference. That's part of what's involved in optimal prescribing. That's what we're trying to achieve, to have every physician optimize her or his prescribing practices. That's what's going to make the difference. And again, similarly, you keep showing this because it is, as Dr. Zauda said this morning, it's an extraordinary map. And folks in the darker colored states, we're pretty sure, don't need antibiotics at 2.5 times the rate of the folks in the lighter colored states. And so what's going on right now by the folks who did this study, Dr. Hicks and her colleagues, is looking at why is that happening? Who is it in these states? What's the profile of the physicians in those states? What's different about those states and those physicians that may be related to this extraordinary variability in how those prescriptions are being written? So what our goal is, so if this is, let's say, a normal distribution, do we want to narrow that around the current midline? Or maybe we want to narrow the variability and move the entire curve to the left. That's what's under investigation. That's the kind of work that's going on right now to begin to answer those questions. So that's what we're measuring, outcomes and process. So I just want to show you a few more slides, make a couple of more points, and then stay on time. How to measure. We have opportunity now because so much of medical information is becoming electronic. We have an extraordinary opportunity to bring in a level of information, a level of data on patients, prescribers, on the laboratory, unprecedented amount of information. The challenge is the complexity of the data, the fact that a lot of electronic medical record systems are not interoperable and don't talk to each other, and the fact that we could get too much information. We've got to be parsimonious in how much information we're going to pull out of the system so that we don't overwhelm ourselves with too much information. But we do have that ability, and we can aggregate the data. We can look at it patient by patient, facility by facility. We can look at it by region. We can look at it by state, as you just saw. We can look at it nationally. All those levels of analysis are going to be important. And we can use clinical and administrative data to measure outcomes, to measure the relationship, as you heard Dr. Flynn say, the relationship between resistance and use. All of that is on the horizon. It is in process now. And we're making significant progress toward achieving those goals. But it's not going to happen tomorrow. This is a difficult and time-consuming process, but we are getting there. Under process, one important thing that I think you only heard very little about, in addition to benchmarking, which we'll talk about in just a moment, of saying, what is everybody else doing? How does your facility compare to other facilities? You saw this morning individual prescriber versus individual prescriber in practice. Then we can do facility by facility. Clinical decision support is the process by which so many physicians are now ordering antibiotics, certainly in the hospital, but more and more even on the outside through a variety of systems and pharmacy systems to track what individual prescribers are doing and to give them feedback in the process of prescribing as to whether their prescription is consistent with guidelines. So these are all things that are going on now using information technology, which is just extraordinary, but we do have to get our hands around these data. Let me just show you a few more slides. Measuring antibiotic use, we talked about. The slide of the United States that we showed you is based on proprietary data. CDC has to buy that data Most of it comes from IMS Health, which collects that data. They sell it back to the pharmaceutical companies for marketing purposes, but it's an extraordinarily valuable data set, but we have to buy it because that information is not readily available. It's proprietary. They own it, and they license the use of it in certain circumstances. We can get facility-specific data. We talked about that. The question of appropriateness of use, talk about this in just on one or two slides up, but appropriateness of use is something we talk about a lot. It's actually something that is measured retrospectively. How do you know at the time that you're prescribing if it's appropriate? You can, as I just said, you can assess whether you followed optimal prescribing practices, but appropriateness, more often than not, is a retrospective decision. Let's look at that in a second. First, let me just show you this concept of benchmarking. This is a mock-up of what a system would look like that is currently being built through the National Healthcare Safety Network at CDC to collect this antibiotic use data. And the theory here is that if you've got enough data and you have enough patient information, you can identify what the expected use of an antibiotic would be in a ward, in an ICU, in an entire hospital. And that's what you see in these columns. Over on the left-hand side is the ward. The next column is the actual use as measured. The third column is the predicted use, what the use would be based on a much broader assessment of data. Given your patient population, what would we predict you to be using? And the fourth column then gives you an estimate of whether you're above or below the predicted. Now, being above the predicted doesn't automatically mean that you're doing a bad job. What it means is that you have to go back and look very carefully at why your antibiotic use is at variance with what have been predicted. So maybe you're doing everything right, and maybe there are a lot of valid reasons, but you have to look at it if you're becoming an outlier. Why is your practice different? That would be an extraordinarily powerful tool. And again, you saw that in Dr. Zaldis' presentation when physicians were fed back their data. So that's the benchmarking concept. We also talked about measuring process, measuring do you have a program and what the elements of that program are. In the state of California, you can go online to this website and find which hospitals in the state of California have which elements of an antibiotic stewardship program. California mandates that every hospital has a program, and now they have to report what elements of the program they have. So it's not only a very convenient measure for the hospitals, but you as a consumer, if you're living in the state of California, you can go online and find out whether your hospital is following this set of practices for antibiotic stewardship. And so one of the last things I want to talk about is this idea of optimal prescribing versus appropriateness. I think those are complementary measures. Optimal prescribing is a prospective measure. Optimal prescribing says, right at this moment, am I doing everything right in prescribing this antibiotic? Are my decisions consistent with the appropriate guidelines for prescribing? Subsequently, you can go back and say, was that the appropriate antibiotic to use in that setting? It may or may not be, but there's a little bit of a disconnect between following all the guidelines for prescribing and appropriateness of use. Retrospectively, you may be able to say you didn't need that antibiotic. You don't know that at the time you're prescribing it. So our goal is to improve everybody's prescribing practices to achieve this goal of optimal prescribing. Last two slides. A lot of challenges. You've heard over and over again, this is probably the single most complex issue in all of medicine and public health. It's got behavioral components, it's got institutional components, there's a huge ecological issue here. Every institution, every physician practice is different. One size, one type of program is not going to be for everybody. The elements need to be there, as you saw, but the exact way that those roll out have got to be adapted to the setting. Tremendous amount of data is going to be available. It is currently available. It's a challenge. to manage and use all that data in the best possible way. And analyzing the data, setting the best benchmarks, risk adjusting is a tremendous challenge. That is, again, going on right now. Those are the systems that we're building, the type of analysis that you've been hearing about for the last day. We do need to do that. It's challenging, it's difficult, but if we're going to make progress in this, we've got to make sure that our data is believable and credible, and that people understand that we're not just throwing a blanket over everything, that we're looking critically at all of the things that people keep saying. My hospital's not like any other hospital. My practice is not like any other practice. My patients are not like any other patients. We'll take that into account. There has to be risk adjustment. Reduction in use of antibiotics is not an end in itself. It's a natural outcome of better practices, both for prescribing and preventing infections. Benchmarking is a useful tool, but within every institution, you need to use that data for continuous quality improvement. The emphasis, as you saw this morning, on continuous. If you don't continue the program, you get backsliding. Optimal prescribing is a key goal to complement the appropriateness of use, and managing this incredible amount of electronic data is something that we're only now learning to get a handle on.